Next, we're going to do a couple tests for lower limb assessment. First, we're going to do what's called a long sitting test. So I have my patient in supine. What I'm going to have her do to kind of reset her legs is bend both of your knees and then do a glute bridge. Just bring your butt off the table and then slowly lower them back down. And then we're going to slowly bring your legs back out again. So I'm going to assess her medial malleoli. You can do this with a pen or just with your thumbs. So we're getting an idea of where those malleoli are sitting in relation to each other. So this is looking at either a functional leg length difference or a structural leg length difference, which could also be caused by a rotation of the pelvis. So as we're sitting, we're pretty even at the moment. So then what I'm going to have my patient do is sit up into long sitting. And then we're going to reassess where we're at. So this right one in my right hand comes a little bit longer, so her left leg. So this could be potentially indicative of a posteriorly rotated ilium, which I would see during my palpation as well when I did her posture, or it could have just been something I missed. And then we'll go back down to supine and reassess to see if it goes back to where we started. So that pelvis is something that we'll look at, and then I'm going to have my patient sit on the edge facing away, and then we're going to do the Stork test, also known as the marching test, depending on what you look at. So I'm going to find my patient's PSISs, like before, the iliac crest, working our way down. So then what I'm going to have my patient do is I'm going to have you lift up your right leg, and we're going to assess to see if that PSIS moves with the leg. Then we're going to do the same thing with the left leg to see if my thumb goes down towards the table and back down. Then from here, I'm going to move my thumb to the same level as my other thumb, but on the middle of the sacrum, and we're going to repeat the same thing again. So right leg, and the thumb moves, and then back, switch to the left leg, and we'll see that it moves. If one of my thumbs is not moving, that's an indicator for hypomobility of the pelvis, which is something we would look into further. From there, we're going to do the forward bend test, which is exactly what it sounds like. We're going to find those PSISs once again, and then we're going to have our patient slowly bend forward towards the ground, ensuring that their feet are on the floor so that they're not going to fall. And then we're looking to see if one of the thumbs comes up first. So my right thumb comes up a little prematurely, so that could be indicative of some hypomobility on the right. So we would assess that further and potentially treat that later. So now we're going to get into some special testing for the SI joint and surrounding musculature. We're going to start with the active straight leg raise. So we have our patient in supine, and what I'm going to have them do is raise their leg just a little bit off the table to my hand, and then back down. So this test is assessing the back musculature and the abdominal musculature to get an idea of the lumbopelvic control with lower extremity movements. So from here, next part of the test is we're going to repeat that straight leg raise, but I'm going to compress her ASISs on both sides and have her do it again. Up and then down. So I would then ask my patient if it's easier or about the same with that compressive force. Yay, nay. Okay, about the same. So if they were to report yes, then that would indicate there's potentially some transversus abdominis weakness, as that ASIS compression is kind of acting as the transversus abdominis in that moment. Next part of the test is we're going to do the same thing for a third time, but we're going to compress the PSISs on the back. So we're going to have you do it one more time, up and then down. And then was that easier than the other two? That was easier. So that could potentially indicate some multifidus weaknesses, which we can assess later in strength testing, and so forth. So that's the active straight leg raise. so indicating core control and control of back musculature as well. From here, since we're already in supine, we're going to move on to the internal rotation supine test, aptly named, as it involves, I'll do that later. So we're going to do the internal rotation supine test, which is exactly what it sounds like. We're just going to internally rotate the lower extremity to get that internal rotation through the hip and see if that causes any pain there. And then we'll do it on the other side as well. Any pain with that? Awesome. So with the maximal internal rotation, we're creating a stretching force on the piriformis, which attaches to the sacrum. So with that internal rotation, we're basically pulling the sacrum into the SI joint, potentially causing some pain provocation at the SI joint with that piriformis stretch. So if they have pain with this, it could potentially be a piriformis pain or it could be an SI joint pain. So we would want to specify if they have pain, where it's coming from, and what that pain feels like. So from here, we're going to have our patient come into sitting towards me. And we'll do the internal rotation, external rotation sitting test, also aptly named. So we're also focusing on the internal rotation and external rotation components for this test, just in a different position. So the way that this is going to work is we are going to be passively externally rotating the leg and then internally rotating the leg all the way out, seeing if there's any pain there. As we internally rotate, you'll see that the hip comes off the table, creating some lumbar side bending. Does that feel okay? We'll also assess bilaterally as well as we would have with the other two tests. So we'll do external rotation. That's my leg popping, not yours. And then internal rotation. So as we internally rotate, we're getting that hip coming off the table, creating a little bit of lumbar side bending, which could potentially create some SI joint pain because it's kind of getting stuck in the middle of the motions at the hip and the spine. This is kind of the equivalent of the quadrant test for the SI joint, creating that compression of the SI joint and pain provocation. So from here, moving right along, we have our sacral thrust test. So if you want to go into prone, fix our sheets here. So the sacral thrust test, in prone, we're going to be doing a posterior to anterior force on the center of the sacrum, which will hold for 10 seconds with a spring at the end. So we're coming here, pressing directly into the table, holding it for 10 seconds, and seeing if our patient has any signs of pain, whether she's wincing at me or looking at me like she wants to hurt me, and then a little spring at the end. So if our patient has pain with this motion, you can also assess the sacral thrust test with hip extension as well. So having them passively in hip extension with that sacral thrust again, which could potentially kind of more isolate the area. And then on top of that, you're also going to want to do some PIVMs of the lumbar spine to ensure that if they have pain with that sacral thrust, it's not a domino effect and the pain's actually coming from the spine in the first place. So we're going to go in and just quickly assess some PIVMs for that lower lumbar spine and see if there's any pain with any of those. Any issues there? Awesome. So make sure with that sacral thrust test that you're also doing the PIVMs of the lumbar spine to assess that we're actually getting the right pain provocation. Next, we're going to do the posterior shear test, also known as the thigh thrust test. We're going to have our patient in supine, and you can do this on either side of the patient. So I'll stay on this side for now, just for camera purposes. So we're going to start with our patient's hip flex to 90. We're going to abduct their leg or adduct their leg in order to get your hand on their sacrum. Then you're providing anterior to posterior force through the leg to reproduce pain at the SI joint. Then we'll also assess this on the other side. Getting our hip flexed again, adducting over, getting our hand underneath on the sacrum, and providing that anterior to posterior force, creating that posterior shear, potentially provoking that pain in the SI joint region. Was one side worse than the other? Is the left side still worse? Okay. From here, we're going to do the FABER test, which is named based on the position that you're putting your patient in. So you're putting them in flexion, abduction, and external rotation, creating a 4 with their leg. From here, you're going to provide a force on the opposite ASIS and their knee, creating a compressive force at their SI joint. And you would also do that bilaterally, bringing them into that 4 position, doing that ASIS and that knee. Still on the same side or worse on the left still? Worse on the left. Still worse on the left? All right. So from here, we're going to do ASIS compression and distraction. These are one of the most well-known parts of the ASIS cluster. So for ASIS compression, it's exactly what it sounds like. You're providing a compressive force on the bilateral ASISs, just like we did during that active straight leg raise test earlier, except there's no leg components to it. So ASIS compression, you can do in supine here, just like this, providing that compressive force for 10 seconds, and you can do a spring at the end. And this is creating a gapping at the SI joint in the back, also for pain provocation. Or you can do ASIS distraction, which is the opposite, creating a compressive force at the SI joint, which you can hold for 10 seconds and then do a spring force at the end. For our patients that are pregnant, they might not like being in supine as much, and it's also a little bit dangerous. So I would have my patient go into sideline to turn this way. So then for here, we would have a pillow in between the legs. Which would probably look a lot more normal than this very fluffy green pillow, but we're working with what we got in our living room. So, you got a pillow in between their legs, and for ASIS compression, you're basically creating that compressive force. Can you scoot back a little bit towards me? Beautiful. That way I can get a better force. So we're compressing through the ASIS. You can use your forearm to help you so it's a little bit more comfortable for the patient. And you're compressing those down in the front. And then you can also do the same compressive force through the back to do the ASIS distraction in the back. So that's how you could adapt these into sideline. You could also do the force through your hand if you don't feel like you're getting the force where you need to. Can vary based on your patient and their gluteal tone, how you kind of got to position your forearm or your hand. If they're still having issues with that ASIS contact, you could also put a towel in between your forearm or your hand as well to make it a little bit more comfortable. So that way you can actually get the SI joint pain as opposed to the ASIS pain because it's tender to touch. So from here, we have Gaenslen's test. So I'll take this pillow back. And then if you want to go into supine, what I'm going to have you do is scoot towards me on this side. I'm going to try to get this leg off the table. So I'll see if that'll reach here. Just get a little bit further if you want. There you go. Make sure they're still on the table so they're not going to fall. And then from here, we're going to flex the opposite leg farthest away from you to maximal flexion. And then you're going to provide a force through the knee and through the opposite knee as well. And this is also a part of that ASIS cluster. You can also do it on the other side if you have them scoot to the other side and do the same thing. Again, bringing that leg off the side of the table, flexing the opposite knee, and providing the bilateral forces through the knee and the other knee. With this test, you also want to keep in mind where the patient is reporting pain. Here, stay on the wall. Come back to the center. Because if they have tight hip flexors and things like that, that could also bias this test. From here, our last one is the hip scour test. You want to keep in mind that this test is specifically for labral tears, so it's more of a ruling out in the context of our pelvic health case, because typically we're focused more on the SI joint. But since it's within the same ballpark, we also want to make sure that we're looking at the labrum of the hip as well. So the way this is going to work is you're going to have the patient in supine and have the hip flexed, and we're providing a compressive force through the knee. So you can typically just get your body on top of that knee and press through. And you're basically going to imagine you're drawing a circle, like you're parking a car, driving a circle around the outside and then back around. So that way you can potentially catch that labrum through the compression and that rotatory motion with the circumduction. So what that's going to look like is you're providing the compression and going in and around and out and then back in and around and out. And looking for wincing like Katie just did that you can't see on the camera, or any signs of pain with that motion as well. So specifically for pain provocation of the labrum, and this test is specific for ruling in labral tears as well. So something to keep in mind within this patient demographic.